A young person asks for specialist mental health care. The referral is accepted. The first appointment happens after 14 days. The system records a wait of 2 weeks. Another young person asks for the same kind of help. The referral is declined. There is no first appointment, so there is no waiting time to record. That difference reveals what New Zealand's mental health wait time number can and cannot tell us. It measures speed for people who enter the service. It does not by itself measure access for everyone who tried to enter. In August 2026, the government prepared to publish waiting times for young people seeking mental health support. The announcement began an argument about declined referrals and regional data. The argument matters because a number can improve, while a different part of the system becomes harder to see. New Zealand's specialist mental health target has a clear clock. Waiting time begins on the date a person is referred to a service. It ends at the first qualifying face-to-face clinical contact. 21 days or less counts as being seen within 3 weeks. The national goal for 2030 is for 80% of people accessing specialist mental health and addiction services to meet that time. This answers an important question. Once a referral leads to specialist care, how quickly does that first contact happen? Long waits can allow distress to grow. They place pressure on families, general practices, schools, and emergency departments. A public time measure can show where services are slow and whether extra staff or a different process helps. But open the calculation and another group appears. The official method excludes referrals that were declined because the requested service could not be provided. It also excludes referrals when another service was judged more appropriate and referrals with no qualifying activity. That makes sense for one narrow purpose. It is impossible to calculate the time from referral to appointment when no appointment occurred. The trouble begins when the narrow answer is treated as the whole picture. Imagine a cinema reporting how quickly people reached their seats. Everyone who entered was seated within 3 minutes. The number sounds excellent. Outside, however, a line may have been turned away because the cinema was full. Seat time tells us how the entrance worked for admitted customers. It says nothing about the people still on the footpath. Mental health triage is far more serious and more complex than a cinema door. Declining a referral is not automatically a mistake. Specialist services are designed for people whose needs meet particular clinical thresholds. A referral may lack information. Another community, primary care, or youth service may genuinely be a better fit. Urgent cases should be identified and seen urgently. That is why the number of declines alone would also be incomplete. Good reporting needs to show how many referrals arrived, how many were accepted, how many were declined, why they were declined, where people were directed next, and whether that next door actually opened. Location matters too. A national average can hide a slow district beside a fast one. It can hide a region where few referrals are made because families or general practitioners have learned that the threshold is hard to meet. In the first quarter of the 2025 to 2026 reporting year, the national result for the specialist access measure was just over 82%. Results by district ranged from above 90% to close to 62%. One region also carried a warning that a new information system had created data problems. Those details do not make measurement useless. They show why every performance number needs a definition and a note about data quality. There is a second missing group before referral even begins. Some young people never reach a general practitioner. Some ask for help but are supported by family, school, a helpline, or a community provider without entering the specialist collection. Others feel they need professional help and receive none. In the 2023 to 2024 health survey, 6.5% of children had an unmet need for professional mental health support. That measure comes from people's experience, not from the specialist appointment clock. New Zealand is also conducting a national child and youth mental health study involving around 6,000 households. It is designed to examine conditions, service use, barriers, and unmet need among people aged 5 to 24. Results are planned for 2028. These datasets answer different questions. Service records show what happened inside care. Referral records show what happened at the gate. Surveys can find some people who never reached the gate. Put them together, and the system becomes easier to judge. Suppose accepted referrals rise while waiting times stay steady. That may show a service expanding without becoming slower. Suppose waiting times fall while declines rise sharply. The service may be moving faster, but access deserves a closer look. Suppose both measures improve while a population survey still finds growing unmet need, then demand may be growing beyond the part of the system being measured. No single number can carry all of that meaning. This is not an argument against targets. A target can focus attention and turn a vague promise into something the public can test. The safer rule is to place a gait measure beside a speed measure. If this distinction helps you read health statistics more carefully, share it with someone who sees a shorter wait and assumes the whole problem is shrinking. The two young people at the beginning leave us with different records. 14 days tells us something valuable about the first. The blank beside the second is also data. New Zealand has to decide to count it.